This is Selma Schimmel, and this is Unique and Unmistakable Amsterdam. The cultural and commercial capital of the Netherlands is used to being the center of attention, and this year is no exception as it hosts the European Cancer Congress 2013. This is a multidisciplinary cancer congress sponsored by ECHO, the European Cancer Organization, ESMO, the European Society for Medical Oncology, and ESTRO, the European Society for Therapeutic Radiology and Oncology. Bringing together the most imaginative and innovative minds and researchers from across the continent and around the world to engage global stakeholders, coordinate a unified oncology community, and speak with one voice. Vital Options Advocacy in Action is here to do the same, bringing together influential leaders of the cancer advocacy community for a three-part advocate forum. This is our fourth European Advocacy in Action, and we are so proud to be in Amsterdam, grateful to be partnering with ESMO and ECHO, and honored to bring it to you. Are the barriers to palliative and end-of-life care by region and country, culture, belief systems?
Yeah, even if there are guidelines and also regulations that actually should guarantee the patient right to have an access to palliative care, it's true that there are still across the world disparities and several barriers that make really difficult a concrete application then of this right. And the barriers refers to physicians, to patients and caregivers, and to the general community. Firstly, I think the most important barriers is a lack of awareness, a general lack of awareness about palliative care and a misconception about palliative care. So palliative care, as we said, are more identified with end-of-life care instead of, for example, of care that could really improve the quality of life, not only of a patient, but also of the family who normally support this patient pathway. So I, for example, represent an advocacy patient, and I should say that patients very often report also an inadequate education among professionals, among health providers, especially in the GPs, because the misconception that they have about the concept of palliative care, and also sometimes also the inability to recognize how advanced is the disease of their patient, the inability to recognize the symptoms, make as a consequence what? That they refer their patient to the palliative care service too late respect of the moment in which they could really benefit and profiting of the palliative care. So this is a very big problem, and this barrier is also made stronger also from a poor communication among the healthcare providers, among GPs and the palliative care service. So there is not interaction, there is not integration in what they normally do. And this as a result also in the life of patients and their family, because there is like a sort of lack of continuity in this pathway. It's like the patient feel like isolated, like alone in his pathway, because the ideal approach will be to have a multidisciplinary approach since the beginning, since the moment of the diagnosis, because actually palliative care could really be provided at all stages of the disease, not all in the end. So to prepare the patient, to inform the patient, to educate the patient about this option would prepare also the patient to accept better maybe the situation and to feel really like since the beginning, to feel like in a family. I mean, not to feel isolated or alone, but to feel still inside of a community. Because the problem when he is referred to a new service is that he has to create a new situation, a new relationship. He has to create really a new way to live his disease.
One of the things which we have modelled into our own system, and which we are spreading through ESMO, is the notion that this needs to be seamless integration. I remember in the back of the ESMO programs, they used to have a model, the 3 elements of cancer care: chemotherapy, radiotherapy, and surgery. And it was like there was a missing part of the puzzle. The missing part of the puzzle was palliative care, and it needs to be there in such a way so when my palliative care nurse gets called to see a patient by one of my colleagues in a clinic, there's no stigma of saying, well, we're sending you to the palliative care clinic, but just rather this is just part of the cancer care package. And it's even without a label. That someone who is expert in looking after your pain, looking after your physical symptoms, or looking after your psychological care is part of the package of cancer care that the centre provides. The names, the labels aren't important, and if they become a barrier, get rid of them. And that when you establish a credible relationship with patients, working with them from the earlier stages, and as the disease progresses, the role of the palliative care team, already having an established relationship, becomes that much easier. That much easier.
Absolutely, absolutely. The interaction is absolutely a key factor, is a really important component of care for the patient, for also the caregiver who should support him. Also because sometimes the problem is also the caregiver, because the caregiver, a part of the fact that many caregivers could not support the patient because they work, but sometimes they are not able to afford this kind of situation. They really don't know how to face to this kind of situation. Also because even the patient sometimes doesn't know so much, and also the fact that there is this kind of misinformation and misconception tend to prevent the patient to adhere. This kind of option is given to him. So this is really a very strong barrier. And adding to these 2 barriers, I can also say, for example, the reference to the management of pain. So the very limited use of opioids, of medications that are normally used to relieve the pain for patients. Limited that is due, in one side, because there are very strict policies and regulations, I think unnecessary regulations, which really discourage physicians in adopting this kind of medication. In the other side, also a cultural barriers of physicians who sometimes are worried that maybe the patient could be addicted of these medications, or maybe it could have some side effects. Sometimes they also don't know how to really manage these side effects. So I think more education, more awareness, more resources also spent in this kind of education should be really important.
I think one of the strongest messages to take away from this is the integration of the dialogue and the discussion early on with the provider and with the family member and with the patient, because if you begin to demystify it and make it, as we talked about, the continuum of care, the puzzle pieces begin to fall into place. Doesn't answer the resource issue, but it begins to help paint a picture and create a safe place for the patient.
One of the things that we're trying to do is to encourage oncologists to say, this is part of what we do, that we're not just here about giving you medicines to control your cancer. We're here to help you to live as well as you can. And yes, the chemotherapy or biological therapies are going to be part of that, but there's a lot more to personalized cancer care than just that. And that my job as your cancer care primary clinician to know about what's happening with your physical well-being, your psychological being, the function of your family. And if we need to bring in other clinical experts to help with these other aspects of your life, well, let's do it. Because it's about forming this relationship of a collaborative partnership, and then to say, well, what are the problems and how best can we build an individualized plan to deal with those problems? I think we need to get away from the model of the oncologist as a chemotherapist or as a drug doctor, but rather to go to the model of the oncologist or the oncology nurse clinician as being a whole person doctor.
Do we then need to break out of the model of palliative care? Do we need to call it palliative care at all?
Look, I don't care about the labels. You know, but on the other hand, whether one wants to avoid the term or whether one wants to educate the public to change, to give them a more informed understanding of what it is, either of them are valid approaches.
Yeah.
But the critical thing is to make sure that the services are there and they're built in, and that physicians and oncology nurses know that this is that bringing these things to the table are a core part of their role.
You know, you said something interesting. We hear about personalized medicine, and we think in terms of personalized medicine as, you know, a biologic or a therapy that's going to work on a certain pathway. When you have said it now, actually, this is very much personalized medicine, and it's a way to even expand what we call personalized medicine, because you're really personalizing it in the fullest capacity for that patient.
Yeah, it's not just personalized biological care.
Exactly.
It's personalized person care.
I like that very much.
I think it's important to have an holistic approach with the patient. So not only focused in the disease, but also in the emotional aspect, spiritual aspect, physical aspect, any aspect related with patient. That is really important to focus on.
And the message we're trying to give is if you're not doing that, you're not providing an adequate standard of care. And so this is a culture shift in the practice of medicine that we've been trying to do. And tonight actually we're celebrating the 10 years of the designated center program of integrated oncology and palliative care services. We now have 161 cancer centers in Europe and around the world that have signed on to show that they are really fully integrating oncology and palliative care. And we hope that by 2020 we'll have more than 250 centers.
You said that there are 165 cancer centers in Europe where these basic services are integrated into standard care. And my question is, how is that defined? Is that the National Health Insurance will not reimburse that patient unless these services are part of the package?
So ESMO is part of an incentive program, an incentive and educational program, developed a model whereby we defined 13 criteria that would need to be met for a centre to be given designation as an integrated centre. And those areas cover adequately trained staffing, a philosophy of care that emphasises continuity of care and the importance of palliative care, practical aspects about the administration of palliative care in the inpatient, in the ambulatory setting, inpatient setting, and in the home setting, the provision of psychological, family, and spiritual care programs, research in palliative care, and education in palliative care. And unless you're meeting all of these standards, then you don't get the designation. And what we're seeing is that because centres want this recognition, more and more hospitals are developing programs to meet these standards. And this has been a real, it's a wave.
So this is, in a sense, it's an ESMO stamp of approval.
Yes.
It's not a national policy that is approved by the ministry and the health insurance and the regulatory bodies within the country.
No,
which would be the end goal, no?
Look, what I would like to see is I would like to see that this to become the standard for national accreditation of comprehensive cancer centres. And unless centres are showing this sort of level of integration, that they should not get that sort of recognition.
Yes, this would be the end goal.
Yeah.
I work in pediatrics, but it is our goal as well for our services that are now available in every hospital. But it should be also recognized by the authorities as such.
Yeah.
Okay, thank you.
Thank you, Dr. Cherny.